This presentation is being recorded in March 2020. I will be discussing Dermamelan, a topical treatment as an alternative to an energy-based device in the treatment of hyperpigmentation. In introduction, hyperpigmentation is a global concern affecting all skin types, ethnic, gender, and age groups. It has a high prevalence and is one of the most common reasons to consult a dermatology or cosmetic practice. Patients report a profound negative impact on their quality of life, so we know that this is a real and pervasive problem. Patients may present at any age. A Woods lamp allows accurate identification of pigment depth, and when planning a treatment plan, one should consider skin type and ethnic group, family history, sun exposure and product use, as well as hormonal considerations, for example the oral contraceptive pill, and menopause. In order to simplify diagnosis, we divide the treatable causes of hyperpigmentation into four main categories: melasma, post-inflammatory hyperpigmentation, solar lentigo, and ephthalites or freckles. Melasma presents as shadow-like irregular lesions with undefined edges and local hypervascularization. The etiological drivers are hormonal, sun exposure, and a heavy genetic component. There are three patterns: the centrofacial, malar, and mandibular. And while these may seem insignificant, there are scores that are useful when making diagnosis, like the Massey index, which will rely on the clinician identifying the pattern of the distribution. Post-inflammatory hyperpigmentation presents as irregular spots, flat dark pigmentation which is localized or diffuse. The superficial lesions tend to be better defined, with deeper pigmentation being more dispersed. The etiology is inflammatory: injury, photosensitizing medication, and UV damage. Commonly it follows acne, injury, or burns, and can be a side effect of any cause of depilation, for example wax or laser. Post-inflammatory hyperpigmentation is more common in darker phenotypes. Solar lentigo presents as oval, round, lentil-shaped spots which are even. They usually measure between 2 and 20 millimeters, but can be much larger. They're intense in appearance on the Woods lamp, and the etiology is sun exposure, age, and there is a genetic predisposition. Senile lentigo occurs over the age of 50, but in very light phenotypes, solar lentigo may present even before the age of 30. Ephthalites, or freckles. These are small, regular pigmented spots which are intense in color and crisply defined. While there is a genetic predisposition to freckles, they are increased in number as a result of sun exposure, and they're common in lower Fitzpatrick skin scores. They're highly sensitive to UV radiation, and patients present with more freckles after a sunny holiday. Pigmentation is visible melanin irregularities. Normal melanocytes are evenly distributed in a regular ratio of 1:36 between keratinocytes, that is to say 1 melanocyte to every 36 keratinocytes. Hyperpigmentation can be caused by local melanocyte overgrowth or migration, or by excess melanin production or lack of clearance. Pigmentation has two primary sources: genetic predisposition and environmental factors, which act in combination. Congenital hyperpigmentation may be benign or form part of a broader syndrome. It can be melanocytic or melanotic. The example of benign hyperpigmentation of a baby is a cafe au lait spot. A child presenting with 1 or 2 may be totally incidental, but a number greater than 5 is commonly associated with a condition, for example neurofibromatosis. Melanocytic pigmentation is a result of an increase in number of melanocytes, whereas melanotic pigmentation is purely the increase in melanin production. Acquired causes of hyperpigmentation. Normal melanin production responds positively to reactive oxygen species and UV light exposure. That is to say, in response, there will be more melanin produced. Melanotic hyperpigmentation, which is melanin production without melanocyte increase, is upregulated by estrogen and mitigated by progesterone. Breakdown of the extracellular matrix that occurs during aging can lead to local feedback signaling failures, causing excess pigment production. External factors like medicines, environmental exposures to photosensitizing chemicals, injury, inflammation, and increased reactive oxygen species production can all lead to local hyperpigmentation. Drivers of pigmentation may be genetic or acquired. Genetic predispositions often require an environmental trigger. Hyperpigmentation may be melanocytic or melanotic. Melanocytic conditions are normally parts of aging or a broader genotype. Melanotic conditions result in excess melanin deposition in the keratinocytes and in the epidermis. Moving on to treatment options and the rationale behind choosing a specific treatment option. Lasers are a critical tool in the aesthetic industry. They allow for selective thermolysis, targeting of specific areas at specific depths. Wavelength, duration, and fluence can all be controlled to allow fine targeting of areas of melanin or melanocyte buildup. Fractional lasers permit treatments which allow local ablation, including pigmentation, which is later extruded along with necrotic debris. Laser has a significant advantage when structural repair is indicated, for example, acne scarring. There are multiple laser types and applications. They're controversial for the use in melasma and post-inflammatory hyperpigmentation, but are relatively well studied, and I've included a comparison here. Significant is the discussion of side effects, and a test patch is indicated in most, if not all, cases. One should consider the treatment time as well as interval when planning a treatment. Moving on to peels in pigmentation. The value of a chemical peel is threefold: the clearance of visible pigmentation, the concurrent treatment of a medical condition, for example, the ability to treat a patient who has active acne at the time, and the control of melanin expression. Clearance of visible pigmentation is by making use of exfoliation of the stratum corneum, the upregulation of keratinocytes and fibroblasts. Melanin is controlled by making use of tyrosinase inhibition. The specific action of Dermamelan starts at the bottom. The general effects are dual. The inhibition of tyrosinase activation within the melanosome, lowering oxidative stress and reducing melanin synthesis. It also acts to reduce the function of tyrosinase because it contains copper chelating agents. Moving on to the melanosome. Dermamelan acts by stopping the melanosome from transferring to the keratinocyte, thus preventing the pigmentation from reaching the superficial layers of the skin. At the level of the keratinocyte, it acts by reducing the amount of melanin formed, reducing the intensity of dark spots. And superficially at the epidermal level, Dermamelan acts on the stratum corneum, stimulating epidermal renewal and intensively combating the buildup of melanin. Constituent ingredients and effects. Dermamelan is a multi-factor approach to depigmentation and skin maintenance. It has more than 30 years of market track record with an extremely reliable safety profile in all 6 Fitzpatrick skin types. Efficacy is well demonstrated in a wide range of in vivo and in vitro tests and trials. Tyrosinase is the main key mediator of melanogenesis within the melanocyte. Dermamelan contains direct inhibitors and copper chelators, primary amongst them being azelaic acid, kojic acid, and alpha-arbutin. A multivitamin complex provides metabolic support. The vitamins include vitamin C, A, B3, and E. It also contains salicylic acid, which is an exfoliant and a keratinocyte stimulator. This is very useful in the treatment of active acne. It also contains retinol, which improves skin rejuvenation. Therefore, while using Dermamelan, the patient's anti-aging needs are being met. Dermamelan treatment protocol. The treatment protocol is simple, and infographics are provided for both the clinician and the patient to understand the application. There's an in-clinic depigmentation, as well as a home maintenance strategy. A thorough pre-treatment consultation is required, as patients may require antiviral prophylaxis if they have any history of herpes simplex. 48 hours prior to the treatment, there is a pre-peel phase, so a 30-minute appointment. And then on the day of the treatment mask is applied in clinic but washed off at home. The treatment duration is related to factors like the patient's skin type and oiliness. The follow-up routine is clearly delineated, with different applications of the post-treatment products in months 1, months 2 and 3, and from month 4 onwards. The in vitro results. Dermamelan results in a clinical efficacy within 48 hours, and one can see clearly a decrease in melanocyte activity of more than 81%. The in vitro trial showed a reduction in the melanin score of 70.8% within 90 days and a reduction of the melanocyte area severity index of 83.5% in the same time frame. This is great for a clinician to be able to see the journey that their patients will be expecting. There's a rapid clearance of pigmentation within the first month, and this continues at a slower rate for a 90-day period. These are the images that both you and your patients will want to see, the comparisons of before and after. One can clearly see in the Woods lamp images the vast improvement after a single treatment. This patient has more severe melasma with a much higher MASI score, and her result is profound. This patient has near flawless skin after an application of Dermamelan treatment. This is the kind of patient that everybody's frightened, with good reason, to treat with a laser. The risk of post-inflammatory hyperpigmentation is extremely high, and any heat-based treatment is so risky. But have a look at her result. One application of Dermamelan treatment cream, and her problem is all but resolved with no complication whatsoever. Post-inflammatory hyperpigmentation is one of the worst complications that occurs in our industry. With Dermamelan, you have the confidence to not only treat the condition, but know that your risk for causing it is infinitesimally low. This patient has both post-inflammatory hyperpigmentation and active acne. Dermamelan represents an option to treat both concurrently. And the patients are talking about it. By searching the hashtag Dermamelan, you will see everyday patients with everyday results that can be achieved in your clinic. Weighing up your treatment options. When formulating a treatment plan, one has to look to one's primary area of concern. Patients with a strong need for structural rejuvenation, for example, acne scarring with a high degree of atrophy, will benefit from first-line laser use. Also, a single deep pigmented lesion like a nevus can be treated easily with a single session of laser. But we're looking for a treatment that has very few side effects and almost no risk of post-inflammatory hyperpigmentation. One should look first to peels. It's also important to note that there are no capital costs required when treating a patient with Dermamelan. No expensive machine to buy and maintain. One simply orders the pack as and when it is required. Lasers and peels both have documented efficacy. The laser risk profile is more significant, and laser is contraindicated in some conditions, for example, active acne. Adding topical treatments such as Dermamelan to clinics offers no capital outlay. Many studies recommend the use of lasers where topical measures have failed, therefore as second-line treatment. Efficacy. Lasers and Dermamelan are both effective in treating hyperpigmentation. Dermamelan has a general multi-level reversible approach and treats other relevant conditions, for example, acne. Laser may be specifically selected for in the case at hand and may be indicated for such comorbidities as scarring and skin damage. Cost. Dermamelan and lasers have a similar treatment cost range to the patient, but Dermamelan has no capital investment or stockholding requirement to the clinic. Safety. Dermamelan generally has a superior safety profile, especially in skin types 4 through 6. Some laser side effects may be irreversible, for example, hyperpigmentation. Conclusion. Dermamelan is effective in all skin types and for many commonly occurring conditions of hyperpigmentation. Side effects are extremely rare and generally reversible. There is no capital cost. There is limited additional insurance implication and no requirement to hold stock. The treatments have a similar cost range to patients, but a significant saving to the clinic. In many cases, topical treatments will be a sensible first-line choice for treating hyperpigmentation, with laser available as a second-line treatment. Thanks for your time. For more information, contact us via the website or follow us on all the social media platforms below. Have a lovely day.